All right, good afternoon, everybody, and welcome to today's panel discussion in honor of Acute Myeloid Leukemia Awareness Day. I'm joined today by four of our editorial board and fellow forums members, Dr. Tristan Knight, Dr. Richa Thakur, and Dr. Joseph Kalis. They have an exciting discussion planned for today to share some of the recent advances and evolving directions in treatment for AML. And we'll also have some time at the end to answer questions. So if anybody has any questions, feel free to type them into the chat and our panelists can answer those later. So with that, I will turn it over to our panelists to start with the introductions. Dr. Knight, if you would like to start off by introducing yourself.
Yeah, for sure. Thanks. I'm Tristan Knight. I am a attending physician at Seattle Children's Hospital in Seattle. I also hold a position at Fred Hutch and the University of Washington in the School of Pediatrics there.
Hi, I'm Richa Thakur. I'm one of the members of the Fellows Forum. Currently, I'm a second-year HEMONC fellow at Northwell in Long Island.
And I'm Joe Kalis. I'm a oncology pharmacist with the UC Health System in Colorado Springs, Colorado.
Awesome. Excited to have all of your perspectives today. I think to start off the discussion, Dr. Knight, if you'd like to start off first, I believe you'll be discussing some updates in CAR T-cell therapy and some evolving directions in that field in AML.
Yeah, absolutely. So yeah, keep an eye on the chat, and if anyone wants to add anything in, just do it. So, and then Kira, if you don't mind interrupting me, because I'm not going to have that message in front of me, but yeah, just please feel free to interrupt. So yeah, I figured I'm kind of by training, I'm an oncologist, obviously, but also a transplanter and cell therapist. And it was debating like how to make this relevant to the broadest possible audience. And being in pediatrics, I mean, I could talk about pediatric AML, but I think more broadly speaking, talking about CAR T-cell therapy and where it is kind of in AML is probably a bit more useful to the broader audience. And obviously, there's some relevance to pediatrics too. So, yes, first off, I mean, why are we thinking about using CAR T-cells in AML? So I'll kind of give some background on that and the rates of cure and relapse and such. So the first thing is basically because our current treatments work in some folks, but not in all folks. So, about 10 to 40% of younger patients and about 40 to 60% of patients over 60 don't respond to induction treatment. And obviously, it has a poor prognosis. About 40% of patients after their transplant will have a relapse. And the 5-year survival for AML folks is about a third of folks still alive at 5 years. In peds, it's a little bit higher than that, well, about 50 to 60%. But obviously, that's still pretty bad. And in peds in particular, AML is one of the ones that does not have a great cure rate. And it's even worse if you're elderly. If you're over 60, which my parents would argue that being not elderly, but over 60, the overall long-term survival rate is about 10 to 15%, which is obviously not great. So clearly, we need additional strategies to treat AML, and in particular ones that are effective and non-toxic or less toxic, at least, in patients who are less fit or who are otherwise not able to tolerate the toxicities of, say, a simple transplant. And that's kind of where CAR T-cell therapy comes in. So I'll give a bit of a brief background about CAR T-cells because not everyone's super familiar with them, although obviously there's a lot of awareness that they exist. So basically, CAR T-cells are in most of the time autologous. So you take the patient's own CAR T-cells by apheresis, you ship them off to usually a centralized manufacturing center, although some centers do have their own local places. You use a viral vector, usually lentiviral, to upload basically a T-cell receptor against a specific target, and then you reinfuse those cells, usually about 2 to 6 weeks later, depending on the construct, back into the patient. So basically what you're doing is you're retargeting the patient's own T-cells against their malignancy. So in ALL and in multiple myeloma, which this talk is not about, this is a very well-validated approach. There are 6 FDA-approved constructs, 4 in ALL, 2 in multiple myeloma, and a lot of experimental ones in trials that target antigens in B-ALL and in multiple myeloma. Now, in those ones, we're talking about CD19 and BCMA as the targets specifically. And a big reason why we're so far ahead of where we are in AML in those other diseases is because these targets are widely expressed on these cancers, and to be mean to B cells, they don't matter that much. By losing CD19 or BCMA, you're not really doing all that much besides getting rid of B cells. They're not widely expressed elsewhere. And you can basically replace what B cells do by giving IVIG or sub-Q IG. So you have the ability to delete those cells without having much of a problem. Why that matters in AML is because you can't do that. So the main targets we're looking at in AML, there's 4 of them. I'm going to go through them one by one and talk about where we are on them and the issues of targeting them. The main ones are CD33, CD123, CD135, also known as FLT3, and CLL-1. And all of those are pretty highly expressed in AML, but they're also highly expressed in other cell types that we need. As a brief note, we know that CAR T cells can work in AML because in about a third of patients who have translocation 821 AML, they actually express CD19, and a few folks have given CD19-directed CAR T cells, which usually are used for B-ALL, given them specifically for AML in that context, and it's worked. It's cured folks. Again, this is case report level data, but it has worked in that context. So with CD19, as I said, getting rid of cells, any cell that has that doesn't really matter that much because you just give IVIG, basically, replace the ability to make immunoglobulin. It's not as targeted, and you still need to be careful, and eventually, you still have that issue, but it doesn't matter as much. In AML cells, basically every antigen just mentioned, CD33, 123, 135, and CLL1 are all expressed on stem cells or multilineage early progenitors or endothelial cells. So targeting those causes problems, as you can imagine, when you delete your stem cells. Doesn't go super well. So I'm now going to get on a brief tour through those 4 targets and going to then focus in the last few minutes about strategies to overcome the issues that arise when you target those cells. So CD33 is, I think, pretty well known to a lot of folks. It's present on most AML cells, including, and this is important, the leukemia stem cells, which are the originator cells of the leukemia. And we know that targeting works. I mean, that's the whole concept of gemtuzumab. It targets CD33. And that drug, obviously, folks, it works really, really well. We like it a lot. But because CD33 is also expressed on stem cells, toxicity exists. A couple of CD33 T cell constructs exist, and we do see in those cells, in animal models and in the lab, good efficacy. But basically what you have to do is mitigate the toxicity by targeting CD33 with the kind of on-target, off-tumor effects. And we'll talk a little bit more about that at the end and how you kind of readjust that. There are a couple of trials that have been launched early on. I think probably the most advanced one is being done by Nurali Shah and others over at in Baltimore at Hopkins. But in general, most of those studies have got pretty good preliminary results if those have been posted thus far. Usually being used in a small number of patients. And the side effects are pretty similar to what we see in CD19 or BCMA-directed CARs with cytokine release syndrome, ICANS, but not beyond what we would otherwise expect. Unfortunately, these folks tend to relapse, and the early CAR T cell designs don't tend to be sufficient for sustained disease control. But we're seeing, improvements. And going back into the history of CD19-directed CARs and ALL, it kind of feels similar to how this felt about 10-ish years ago, where we were kind of still trying to figure out how to use these CARs effectively and how to have sustained responses. But we're as I said, 10 years later for BAL now, we have 4 FDA approved products and multiple trials. So it's definitely very hopeful about where we are with CD33. So there's definitely a lot of validity to using that as a target, but it just needs ongoing refinement and ongoing work on how to do that. Another target is CD123, excuse me, which is part of the IL-3 receptor involved in cell signaling. It's found on many immune cells, basophils, plasmacytoid dendritic cells, hematopoietic stem cells, to a limited degree, but still there. And it's significantly overexpressed in AML cells, including leukemia stem cells, which makes it a target for therapy. High 123 expression, correlates with specific mutations, FLT3-ITD, NPM1, and other mutations, many of which have a poor prognosis. So that's a good thing because, I mean, the AML cells that are hardest to treat are obviously the ones that have the high-risk mutations. The key challenge, as I said, and this is true for all of them, is that it's expressed on other tissues as well, including endothelial cells, which creates a pretty high risk of toxicity. And as a transplanter, anything that targets endothelial cells is terrifying because of the risk of VOD-SOS, veno-occlusive disease, or sinusoidal obstructive syndrome, and causing damage to blood vessels. Puts you at risk for many complications related to endothelial injury. Beyond just liver injury and such for VOD-SOS. So that's kind of a question mark about how that will work. And we do see a bit more in the early trials, a bit more CRS, more GVHD in folks who have gotten CD123-directed CARs. But again, there are some early indications that this is a target that is effective. FLT3, also CD135, most people in AML know it as FLT3, same thing. Also promising target. FLT3 in normal cells is part of hematopoiesis, expressed on leukemia, expressed on normal stem cells, on leukemia cells in majority of patients, and particularly in patients who have FLT3 mutation. Also ones who don't have FLT3, but mostly we see it in the FLT3 context. Mutations cause FLT3 to be constitutively active, constantly active, where basically you have the ability to not turn off. Usually FLT3 is tightly regulated because it controls hematopoiesis, but if you have it always on with FLT3-ITD, you have this constant proliferation. So targeting it's very attractive. That's the whole idea of FLT3 inhibitors is based around that idea. And in CAR T cell studies, the idea is that you could target that as well and have the same effect. Preclinical work has demonstrated that this is definitely an effective approach. Leukemia cells and stem cell and animal models, it definitely has efficacy in getting rid of leukemia cells. And we see the same issue toxicity basically in that is that FLT3 is, even though it's present in AML, it is still an important signaling molecule for FLT3 in normal hematopoietic development. A target approach for that is to use FLT3 ligand-based CARs, where you target not FLT3 itself, but FLT3 ligand. And that appears more effective against AML with FLT3 mutations. And it might not trigger survival pathways in cells that use normal FLT3, so it's an option. Combination therapy is kind of a cool idea. So some folks may know that when you use a FLT3 inhibitor, say gilteritinib or midostaurin, the response from the AML cells is compensatory. So they upregulate that molecule FLT3 on the surface. It's because they're relying on FLT3 for their own survival. They're very clever that way. So an approach that's been used and it's being explored is giving combinations of FLT3 inhibitors and FLT3-directed FLT3-directed CAR T cells. Basically, you have upregulation happening and some, control effect from the FLT3 inhibitor. And then you have the CAR T cell coming in and seeing those upregulated FLT3 molecules on the cell surface and getting rid of them with higher efficacy, which is a really cool approach and uses their own adaptive mechanism against them. The final target is CLL1, seen on most AML blasts, leukemia stem cells, and is responsible for a lot of relapses, but again, also expressed on it's not expressed on typical healthy hematopoietic stem cells, but is expressed on granulocytes and monocytes and progenitors. So unlike in BALL, by targeting CD19, where you lose kind of the mature B cells, you unfortunately end up targeting a lot of the myeloid lineage, which is a much broader set of the immune system. So early trials in CLL1 do show good efficacy, including some cases of complete remission. The problem is that CRS seems like it's particularly common and severe in this target. It's not clear why that would be the case, but it certainly is some of this a higher risk. It's also cytopenias are a much more common side effect, again, probably because it's targeting the healthy myeloid cells as well as the AML blasts. So CLL1 is a useful target, but again, more work needs to be done to kind of how to focus that and not have the side effects. So for the last bit of this talk, I wanted to give some really interesting, I think, cool approaches to mitigating these toxicities and how you kind of avoid running into these. The first one is probably pretty intuitive to a lot of folks who work in the stem cell transplant space, and that's basically that you don't care. You say, well, it's going to delete the stem cells, it's going to delete the myeloid cells, so whatever, we'll do a transplant afterwards. This has been used again in B-cell ALL with great efficacy, where basically you give a CAR T-cell infusion, and then 2, 4, whatever weeks later, you use that remission, and then you do a transplant for someone who we cannot get into remission any other way. And that's been done and it's effective. Problem, as you can probably imagine, is the cost. Transplant is not a cheap thing. It's one of the most expensive things in modern medicine to do. Depending on your way it works, it's between $200,000 to $400,000 for a transplant on average. And then you pair CAR T-cell with that, which is probably one of the other most expensive CAR T-cell or most expensive options in modern medicine. You're getting to $500,000 plus, $1 million plus, without even really having any long-term side effects and such. So this is a obviously expensive approach. The joke with that used to exist and still exists is that the reason they call them cars is because you could buy a very expensive car, a Lamborghini or Ferrari, for the cost of a car. And so combining these two approaches, while it is effective, is very expensive. So that needs a little bit of adjustment. The other approach, and this is really cool, is actually targeting CD33 or CD45 and modifying them in every other cell that's not an AML cell. So, as I said, these are early important molecules in hematopoiesis. So if you can target these with CRISPR techniques and do a transplant functionally, an auto transplant, where you take out the patient's stem cells, modify CD33 or CD45, and then retransplant them, the AML cells won't see the benefit of that because they're further differentiated. They're still immature, but they're more further down the line than the stem cells themselves are. So now if you target CD33 in some way that is targeting the non-changed CD33 or non-changed CD45 and get rid of that, well, you can cure their AML, and the functional remaining CD33 or CD45 is still doing what it's supposed to be doing. You haven't interfered with its ability to function. But you basically have gotten rid of the AML by targeting the old epitope. And so that's been done experimentally and is being worked on a little bit in human trials as well. But again, this is all early phase, but really exciting space. And it's, I think, a very, very useful way of potentially overcoming this. Obviously, the long-term side effects of that are not well known. We don't have long-term data yet on any of these, really. So it's kind of a cool area, but there's a lot more coming, I think. And again, I'm not, hard to predict the future, but I suspect in the next 10 years, I'll be doing this talk again and, be able to say that, 10 years ago, AML wasn't very effective. 10 years from now, maybe we'll be having FDA-approved constructs. We'll be where we are with BALL, in that it's not a frontline therapy, but it's, second line functionally, folks have relapsed. So I'm cautiously optimistic by seeing the data that's out there. There's some really cool work being done, and I think that it's a reason for optimism. So yeah, I'll conclude my part there and answer. I don't know if we want to wait for questions to the end of this or if we want to do questions now, but I'll let you folks go from there.
Yeah, thank you so much. That was an incredible overview. I personally learned so much about what the current treatment is for AML, so thank you so much for delving into that. We do have one question now if you'd like to answer it. Someone asked, do you have any recommendations for first-line therapy for patients with the KMT2A mutation?
Anyone, I can answer that. I can try and answer that. Again,
yeah, go for it.
But so I'm not sure if this is aimed at pediatric focus or if this is aimed at adult focus. But in peds, probably we would just treat these kids per our usual approach. They'd certainly be on the high risk end of the spectrum. I was looking over our current COG risk stratification, and to my recollection, KMT2A is a high-risk mutation. So basically, you would have your standard 2 cycles of induction, 1 cycle of consolidation, and then transplant. What we would do, but we wouldn't use anything specific beyond that in peds, anyways.
Yeah, at least in the adult medicine world at my center, I don't have anything coming to mind that we would be doing specifically differently because of that mutation.
I guess I would say the same thing. Usually, I'm assuming they this is like a new diagnosis, haven't been treated, and if they're fit, probably 7 and 3. Otherwise, maybe like venetoclax with a hypomethylating agent for like a non-curative intent usually.
So yeah, hopefully that answers your question.
Yes, definitely. All right, so I think that transitions into Dr. Kales's part of the discussion. I believe you're going to discuss some novel combinations and how we're transitioning to those, and as well as IDH inhibitors.
Certainly. Yeah, and Dr. Knight touched on some of these. Dr. Thakur brought up 7+3 and venetoclax and azacitidine. And for anybody out there in the audience who might not be familiar, when we say 7+3, we're referring to combinations of cytarabine and an anthracycline like daunorubicin. Kind of been the tried and true approach over the years. But one of the challenges we run into that is not every patient is able to tolerate that or is able to go through it. So over the recent years, the past, I'd say 2 to 4 years, depending on when you start your timeline, we've had combinations like venetoclax and azacitidine or decitabine, a hypomethylating agent, come through. Dr. Dan Pollier up at our Denver location here at UC Health, I think, was one of the pioneers of that approach, because we think of hypomethylating agents like azacitidine or decitabine. I explain them to learners and to patients. We think about them as switching different genes on and off. We want the tumor expressor genes turned on to try and shut down the leukemia as best we can. Venetoclax, I find personally interesting as the pharmacist or the drug nerd in the group. We use it in many other hematologic conditions because it's re-enabling a cell to go through its normal death pathway, apoptosis, as we call it when I want to sound fancy. But in leukemia, what I find particularly interesting, and I apologize for any PTSD I may trigger in like biology students by referencing the citric acid cycle, but what we've learned is about the metabolism of leukemia and leukemia stem cells, like Dr. Knight mentioned. They really are overly reliant on certain metabolic processes, where they're getting their food, where they're getting their fuel. And we've learned that venetoclax can certainly interfere with that. So we've got a multi-pronged approach with the venetoclax and azacitidine, where patients we wouldn't have been able to treat in the past with a harsher regimen like 7+3, or other regimens like cytarabine subcutaneously by itself that we didn't really see stellar responses from, are now able to have a decent chance of at least some disease control and remission while still trying to minimize some of that toxicity. I mean, at my center, we use azacitidine most commonly on a 5 to 7 day schedule. So we might see a patient every weekday, sometimes on a weekend. Venetoclax is oral. They can take it at home. Fortunately, has few side effects. In the AML space, we don't see as much of the tumor lysis syndrome that we might in CLL or other conditions. So it's been a very beneficial approach for some of our more elderly patients, those whose disease may have relapsed, or even I can think of several cases where we've had a patient refuse cytotoxic regimens or transplant. We've been able to successfully use a venetoclax and azacitidine-based regimen. Transitioning a little bit to the other topics Kira mentioned, like IDH inhibitors. Again, Dr. Knight touched on FLT3 inhibitors and others. It's interesting for me as a generalist. I come from that background of, well, in lung cancer, I can put a targeted oral agent at somebody, and that's their entire treatment. Whereas here in AML, I think simply because of how quickly the disease evolves and grows, it's often part of something else. So like, again, Dr. Knight mentioned midostaurin, gilteritinib, we're not using them by themselves. It's in combination with something else. And I see the same thing with the IDH inhibitors like ivosidenib and enasidenib, depending on which IDH mutation a patient might have. But the one thing I'd leave our viewers with today about the IDH inhibitors is they've got a somewhat unique toxicity of differentiation syndrome. And my way of remembering this is IDH is one of those cell checkpoints. If we can stop a cell there, I make the analogy of all of us growing up and going through school. So, elementary school, high school, and then whatever comes after. But if you can picture the cells getting stuck in high school, that's kind of what those IDH1 and 2 mutations do. So when we give an inhibitor, it almost releases them out of high school, out into the world where they're grown up and now have to figure things out. And that's how I logic my way through differentiation syndrome. But certainly something to be looking for if you're using these agents or if you've got patients on them. So thank you.
Awesome. Thanks so much for sharing all that information. And Richa, I think we can transition over to you now as well. I believe you have some updates to share about MRD testing or other aspects of the field that you see.
Sure. So in terms of MRD testing, it's been called minimal residual disease, but the more clinically accurate term is measurable residual disease. So really the difference is when you use measurable residual disease, it's something that's objective. You actually have a measure to look at versus minimal, it's subjective. And it also, in my opinion, kind of minimizes how important MRD positivity or negativity is in the status of the patient. In terms of liquid malignancies versus solid tumors, one of the ways I really think about MRD is kind of like a version of circulating tumor DNA for blood cancers. So the biggest way that I see a lot of benefit for this is it's really like an additive tool to help with decision making. But unfortunately, right now, especially in the area of AML, it's how to guide therapy isn't exactly standard of care, but there are a lot of different clinical trials that do help in this area. So in general, when you think about things like different types of leukemias, like CML, chronic myeloid leukemia, we can use MRD testing to keep checking patients for basically abnormalities in their blood with their fusions, and we can decide whether or not we should stop a TKI. But with AML, that really hasn't been proven so far. So what really has shown much benefit in like the AML population is really the prognostic significance of it. And then the other side in terms of clinical decision-making is still in clinical trials. So in general for MRD, there's 3 big buckets of ways we can test MRD for patients. So generally there's flow cytometry, PCR, and then next generation sequencing. So in a very broad overview, what flow cytometry does, it looks at the phenotypic makeup of the cells, whereas PCR really gets down to the DNA fusions or like the genetic mutations. And then next generation sequencing is even more personalized in terms of the genetic makeup. So what's really helpful is PCR you can actually use for a lot of types of AML, but you really have to have a mutation where the primer is specific to it. So like NPM1 is a very great example of which we can use in this case. And then flow cytometry is really helpful for MRD testing in most types of AML, as long as there's a clone that you can track. And the reason it's MRD is so important in AML is just there's a very heterogeneous population of AML cells whenever you look at cancer on a molecular level. And so even when a patient has been treated with one type of regimen, you don't really know what is persisting down the road after induction or consolidation. And using this type of sequencing will help figure out which types of clones that we need to focus on. So I had talked about the benefits of basically prognosis, right? So in general, if a patient has induction chemotherapy, and in the olden days, we didn't really have MRD to prove this, but now when you finish induction consolidation, all treatment, if a patient is MRD negative, their overall survival with AML is about 68% at 5 years. So that's for MRD negative. Assume that the MRD had converted to positive. In this setting, it's actually about half that, so about 34% at 5 years. So this is a really great marker for us to use in terms of prognosis, and then also to catch early relapse of the disease. And the other clinical trials that have been going on in general are to really figure out where we can de-escalate therapies. So in general, based on genetic mutations for AML, according to the ELN criteria, we divide patients into favorable, intermediate, and high risk. And in the high risk groups, using MRD testing isn't as well proven in the adult population, but there's a lot of great benefits and data in the intermediate and the lower risk populations where we can consider de-escalation of therapy. So there was a recent trial that looked at patients basically that had completed induction chemotherapy were MRD negative versus MRD positive. And so for the MRD negative population in this subgroup, these patients went on to consolidated chemotherapy or auto transplant, whereas usually we had been doing allo transplant for AML patients. And then for high risk AML patients, these patients went directly to allo transplant. So in this setting, there was really no difference between overall survival or progression-free survival. So what this shows is that there is probably a subset of patients that we can spare toxicities to in terms of an allo transplant as opposed to an auto transplant. The other area that's not clearly tested is basically patients that are not getting like intensive chemotherapy. So usually we do 7 and 3 for intensive curative intent in adult patients. And oftentimes if a patient is a little bit older, more frail, or has a lot of comorbidities, we often choose venetoclax with a hypomethylating agent base. And discontinuation of therapy in this population really hasn't been clearly proven as beneficial with MRD testing, but it is helpful with prognostication. The last part where this is, I think, one of the trials that I was most excited about too, where they looked at patients with an NPM1 mutation, because I think this is where you have probably the best benefit. And in this subset, ELN guidelines do recommend testing MRD with PCR in your blood. So usually these there's 2 benefits when you check with PCR. Oftentimes to assess for response, patients would have traditionally gotten bone marrows every month, and then we would space them out further out in treatment. Now with, especially for patients with an NPM1 mutation, this can also be checked with blood. So recommendations for this population, usually you check after 2 cycles of intensive chemotherapy with bone marrow and blood, and then bone marrow at the end of treatment, and then bone marrow every 3 months with, or the other option would be peripheral blood every 4 to 6 weeks for 24 months. And so one of the benefits for patients is that if you do have a genetic mutation that can be detected with PCR, you can spare some of the bone marrows. But especially with the NPM1 population, there was a study by Othman where they looked at patients that had an NPM1 mutation, finished treatments with venetoclax and then another agent with it. So it was either low dose cytarabine or a hypomethylating agent. And when they were checking MRD, it really showed a significant response as long as the patients were MRD negative. But what was the most interesting to me in this population was a subset of these patients that were MRD negative also stopped treatment. And so these patients remained MRD negative and had about a 2-year treatment-free remission for about, I think it was 85, 90-ish%. So this is pretty huge because it's another way you can track blood, right? Like a patient's response to treatment with blood. And also prevent maintenance chemotherapy, decrease visits. So it's definitely a great tool to add to our kits. It's not quite standard of care yet, but I have a feeling in the next couple of months to a year, we'll start seeing more clinical decisions made on this.
Great. Thanks so much, Dr. Thakur. That was a really great way to round out the conversation about not only therapies, but testing how effective they are and being potentially able to de-escalate or stop treatment as a result. We did just have one more question come in. Someone asked, when do you recommend patients participate in a clinical trial?
I can start with that if you guys want. In peds land, always. So again, I'm not sure how old the patient you have in mind is, but in pediatrics, ignoring St. Jude because they're special and they do their own thing, cool things, but they're kind of separate. Anywhere in North America, you're getting the same thing. You roll into somewhere in Toronto, in Vancouver, in Miami, in Seattle, in California, wherever, you're going to be ideally enrolled on a Children's Oncology Group COG study. And COG is a consortium of functionally all oncology centers in pediatrics. Some of the studies go up to adult, age folks, younger adult patients, 25 or 35 in some cases. And if there's an open Children's Oncology Group study and you're eligible for it, there'll be a, team will approach you about enrolling on it. And so the reason peds oncology has advanced so much in the last few years, or years, decades, is because there's such a huge emphasis on clinical trials in pediatrics. I think the recent figure I saw was that if you are clinical trial eligible in pediatrics, something like 90% plus of folks are enrolled in a trial. Again, that's something one is open. In PTAML, I can talk about the current protocols that we have open right now for Children's Oncology Group across North America. But yeah, in pediatrics, if there's an open trial, we strongly urge. I mean, obviously, like it's informed consent discussion and everything, and gold standard and all. But if you don't enroll, you're still getting the gold standard. But the gold standard changes obviously over time. But yeah, so if you are a pediatric patient or someone who's being treated at a pediatric hospital with AML, even if you're an adult, so AYA population, you'll be recommended to be enrolled on a clinical trial much uniformly. A one is open for that disease and that disease indication, mutations being specific involved. So yeah, that's the ped side of things. We try.
Yeah, I'd say the adult side, my side, or maybe trial enrollment rates are not quite as high as in peds land, as you called it. But I know for our populations, we do try and screen everybody for potential enrollment based on what trials are open or what trials we can refer someone to. And then I think one factor to also consider is the patient decision. Are they open to certain types of therapy? Are they open to a clinical trial? So it is discussed with all of our patients, but not everyone is either eligible or willing to proceed.
So I really personally, I'm a second-year fellow at Northwell, so in New York, and fortunately we're at a site where there's so many different centers in one area where patients have access to tons of clinical trials. And in general, I definitely would always recommend patients at least hearing out the clinical trials team at the very beginning, because you never know what the next line treatment will be. Specifically for AML, I think in adult land, there's a couple of things. So if a patient's really newly diagnosed with AML, there's already a really good standard of care treatment that's available for adults. So the only thing I would be hesitant about in this very tiny population is if the clinical trial is withholding standard of care. Most clinical trials will not do this by principle. What they do is they add something else that has potential benefit to what's already approved. So like a really great trial that we have at our institution is adding physical therapy too. So like a patient like this, I would always recommend adding something that could possibly consider benefit. And in general, clinical trials are really a great way for patients to get access to treatments that aren't quite yet approved, but would shortly be approved in oncology in a few years. So I think especially in HEMONC, compared to other departments, clinical trial access is absolutely essential for patients.
Awesome, thank you. Those are all really insightful answers. So as we wrap up, do any of you have any parting words or words of advice in honor of AML Awareness Day, whether it be a piece of advice for clinicians who are treating AML, or maybe some words of hope for patients with AML who are undergoing treatment right now?
I can start again if you folks are okay with that. So for patients, I would say that AML is a very scary diagnosis. I mean, Google is not your friend when it comes to looking up stats. So again, this is when I tell my families is that, especially for pediatric folks, and for younger adult patients, a lot of the data out there is very specific to various circumstances. I'd quoted before, some pretty scary rates of control and survival, but that's kind of specific to certain contexts. And the other important thing, and this is really important, is that I say the survival rate at 5 years is 30%, say, or 60% or whatever, that's 5 years ago or more, actually, because that's, takes time for that trial to move forward. So in those last 5, 6, 7 years, things have changed. Those people were not enrolled on the trials we have access to now. We're not getting the standard of care, the supportive care, the other things. So you're always looking at a lagging indicator. So that's true in every cancer, not just AML. So that's, I think, a lot of reason for hope. Even if it's a scary rate, then things will have changed, because I guess the good thing about things like AML, if there is a good thing, is it's a common cancer, so there's a lot of time to do trials. You never want to have a rare cancer. You don't want cancer, period, obviously, but you never want to have a rare cancer because it's harder to do trials in that space. There's fewer patients, there's less data. But in AML, there are some really cool things, and Joe, you talked about some of these inhibitors, and those I think are moving more and more frontline in peds as well as in adults. There's more trials opening for them. So, that's I think a really important thing for patients. For clinicians, I think the important thing, again, from my mind, is the importance of trials, because as I mentioned, exactly, like, it's the reason we've advanced survival rates so much is because it's constant trial access. So if you look at any curve, done by decades or by years, it's always this kind of series of lines that are like low, lower, sorry, low, a bit less low, a bit less low, moderate, high. Like we're constantly making improvements, and there was a space for AML where nothing new was being approved for a long, long time. But in the last 5 years, I want to say that something like probably half a dozen different therapies have been approved by the FDA for various indications, probably more than that actually. And that comes from trials. I mean, it can be a pain, and it takes a long time to enroll patients, and the data review stuff is obviously a pain, and it's a lot of time, but it works. I mean, getting folks enrolled in trials, painful as that can be, and complicated as that can be, is really important, and it's why the field is moving forward. So I guess that's also for patients. If it can be scary to hear, we're having a trial and we're going to give you a new medication that hasn't been tested in this population or whatever. But the worst case scenario is getting the gold standard plus something else. And if that's not working, it's not like we just toss you off and say good luck. Folks who are on the new agent are being very closely followed, and if they are, something is going on, that's going to be caught pretty rapidly, and that's because there's monitoring constantly. So it's not like we're just kind of going to guess and see what happens. It's those trials are closed. If anything, if there's an adverse safety signal, if it's for some reason working less well than the gold standard, that's caught pretty early usually, and we'd make those changes. So personally, as someone who treats folks on clinical trials, I'm reassured by that, because it means that, as soon as we hear back from the data safety committee that there's something wrong going on, we get letters to us, notified, and that arm of the trial closes down. And if we need to, we switch folks off that arm of the trial onto the other arm of the trial. If it's necessary. Usually it's not, because usually it's like, there's no new enrollments. But I think that's a very reassuring thing. There's constant, this huge background infrastructure happening about the trials. So I think, yeah, clinical trial enrollment is my what I would say is the important thing for clinicians and for patients from different sides.
Yeah, I'll just briefly echo that. I think you really encapsulated it well there with 5-year survival is what it was 5 years ago. It's a common discussion I have with patients of all types and walks of life. The numbers are out there, but they're simply just that. There's science is continuing to advance. We'll find something that we can continue to treat you with.
I'm not really sure how I can top that, but I guess I would say 2 things. So for patients, make sure you go with an oncologist you trust, and don't be afraid of getting a second opinion, because oftentimes a second opinion is what would lead you to a new clinical trial. Chemotherapy is the same wherever you go, but every institution has different clinical trials. And so at least getting another opinion, if you're not sure what to do, don't be scared about that. And then I would say, as for physicians, because of my background as a palliative care physician before I started hem-onc, I have a huge bias towards palliative care with heme malignancies. Unfortunately, the disease trajectory for acute leukemias is very different, and it's not as predictable. And so always thinking about supportive care on top of your treatment at the same time is what I would recommend to clinicians.
And just to add briefly to that supportive care thing, even as the decade curves, like every year or every decade or every 5 years, it's gotten better and better and better. And in AML, ignoring some of the cool new agents we're using regularly, in AML, we didn't have new agents for decades, really. And the reason those curves got better is because, as Richa was saying, supportive care was getting better. We had better approaches to antibiotic prophylaxis, to antifungal management. So yeah, supportive care is nothing to be sneezed at. Like that's why we made improvements, even when we didn't have improvements in the actual drugs we were using. Supportive care is kind of key. So yeah.
Amazing. Well, I think that's a great way to wrap up the conversation. So thank you all so much for sharing these advances and these words of advice and words of inspiration. It's really I'm glad you're able to raise a little bit of awareness today for AML Awareness Day and share these messages with both clinicians and patients. So thank you all so much again for this conversation, and thank you to everybody for tuning in today. Hope you all have a great rest of the day.